increases to 79%. Extra stress for the patient, probably more waiting time, which could delay treatment. Hi friends, welcome back to the channel. I'm Filip, a medical doctor and PhD student here in Croatia, and on this channel you can join me on my journey through medicine and science. Today I want to talk a bit about diagnostic tests and how they're really not perfect, but still very helpful to help us reach a final diagnosis. So basically, whatever we do, whatever procedure or action we take to bring us closer to a diagnosis can be considered a sort of test. And let's sort of look at tests like they can only be positive or negative for now, yeah? So if a person has a disease, we sort of want a perfect test, so some which would be always positive when a person has a disease and always negative when a person doesn't have a disease. But unfortunately, of course, a perfect test does not exist, and a test can basically be wrong in two ways. If a person has a disease, but the test comes back negative, then it's a false negative, right? Because we got a negative result of a test, but it's false because the person actually does have the disease, but the test didn't identify it. And on the flip side, if a person doesn't have a disease, but the test comes back positive, then it's a false positive because the person doesn't have a disease, but the test came positive. Now, every test sort of gets some false positives and some false negatives, and really how good a test is determined by how often it gets a false positive or false negative compared to actual positives and actual negatives. These sort of parameters are known and can be expressed as numbers, which we can use for calculation. So let's take a disease as an example. Let's take glaucoma. So an ophthalmologist is certainly very often in contact with patients whom he might suspect have glaucoma and wants to diagnose it. So for this example, I'm going to be using numbers from a scientific article by Dr. Filip and colleagues. I will link the full article in the description so you can check it out if you want. There's also within the article more detailed calculations than the ones I'll be mentioning here today. So basically, let's say that a person comes to an ophthalmologist and there's no known glaucoma or other disease. What's the probability, or what are the chances that this patient has glaucoma before we do any tests? There's got to be some chance, right? Because we know that glaucoma exists, and it exists in a certain number of people in, say, one country. Now, this is something which is actually often either available on a national level, or at least an estimate can be drawn from the literature. So in this case, the authors used a number of 2.5% as mentioned in some previous literature for their country. Okay, so before the patient comes or before we do any tests, the chances that this patient, since he came to an ophthalmologist, he probably has some sort of eye condition, right? The chance of him having glaucoma is, let's agree, 2.5%. Now, of course, in theory, we could say, okay, I'm confident enough that this 2.5% probability is enough, and I'll just give this patient the diagnosis based on that. But of course, that would be clearly very wrong. So we are sort of compelled to perform a diagnostic test which would bring us closer to the truth. And we would probably start with something simple, inexpensive, something that we can do immediately, like measuring the blood pressure in the eye, which is something which is routinely done in an ophthalmologist's office. So the ophthalmologist measures the blood pressure and the value is actually increased. He has elevated pressure, so we can consider this a positive test. Now, does this mean that the patient has glaucoma? Is this a guaranteed test? How good is this test? How often does it produce false positives, false negatives, all that? When we take those numbers into consideration and like I said, you can find the full calculation in the article, in the description. We actually come to a number that from the previous 2.5% probability or chance of the patient having glaucoma, with this positive test, the patient now has a 16% chance of having glaucoma. So it's far from perfect, right? We would want a test that gives us 100% certainty, yes, this patient has glaucoma, or no, this patient doesn't have glaucoma. And I'll sort of focus only on the positive tests for this example, but the similar concept can be applied to negative results. So it's only 16%, like, was it even worth doing this test? That's basically still nothing. So basically, this is a finding which justifies further testing. If this finding were negative, we probably wouldn't even continue with additional tests, because coming from a probability of 2.5% and then having this negative test, which would mean the chances are even lower than 2.5%, that's, we can be fairly certain that that patient wouldn't have glaucoma. But since this test is positive, and this has increased the chances of him having or her having glaucoma, we should really do another test which would sort of shed some light on the whole situation. So we perform the next test, which is also sort of inexpensive, also can be done. We examine the optic disc of the eye, which is also something which can be routinely done by an ophthalmologist. And in fact, these findings are also consistent with, say, a positive test for glaucoma. But of course, this is a different test, so it has a different number of false positives, false negatives, etc. And now the probability from that 16% after the first test increases to 79%. So still not 100%, we're still not entirely sure, but still a dramatic increase compared to those 16%, right? However, we sort of now enter a gray zone. There's no fixed percentage where we can say, okay, if it's more than this percentage, then we are absolutely certain, because it's never 100%. So it's really up to the physician and the patient's wishes, etc., which will determine whether more tests are warranted. In this situation with 79%, I'm guessing most people would do an additional test. And okay, now we've sort of exhausted our resources in the sense of inexpensive, routinely used tests, and we ordered the patient for a more complex, more expensive, etc. test. And let's call this just GDX, as they abbreviated in the article. It's basically a type of examination of the nerve which connects to the eye, which can be routinely done like the other two tests. And let's say this test also came back positive. Remember, we were at 79% chances or probability, and now with this positive test, the probability becomes 98.7%. So now I think it's fair to say that we can be very certain that this patient has glaucoma, even though it's still not 100%. There's still some chance to be wrong, but we've sort of come to a very high level of certainty, and it's very questionable whether additional tests would actually be useful here, because really, is the difference between, say, 98.7% and, for example, 99.5% really worth an extra test? Because remember, an extra test is always extra stress for the patient, probably more waiting time, which could delay treatment, which could be detrimental to the patient's vision, health in general. It's more cost for the hospital, and it's probably not justified by any sort of standard. So at this point we would say, okay, we are 98.7% sure, I'm giving this patient a diagnosis of glaucoma. Now, that's sort of also why doctors order so many tests, because there's no, in most cases, there isn't really one test which we can give you to see, okay, yes, you have it, or no, you don't. but rather each test is a piece of the puzzle, and when we look at all the results of all three of these tests together is only when we can be sure that we've given the right diagnosis. Check out my video on why doctors smoke, and don't forget to subscribe and hit the bell. Thanks, and I'll see you later.